So I am joined with Dr. Ziad Asi, founder of Precision Health, and Dr. Patrick Mullen. We're both board certified physicians practicing holistic and full scope in Sarasota, Florida. We are going to do a rapid fire round we call fact or snake oil, where we take comments, suggestions, or hearsay online and we put it to rest. We say, what is a true fact? What depends? And what is snake oil? So those are your three answers.
I'm ready, Patrick.
Okay. So our first claim today is that osteoporosis is a woman's problem. Men don't need bone scans.
And my three answer choices were?
Fact, it depends, or snake oil.
Got it. I think that one's just a no. It's not a snake oil. Nobody's trying to sell you anything. I think to be snake oil, you have to be sold. So the answer is no, it's not just a woman's problem.
All right. Tell me more.
As we age, our bone density decreases. It is a fact. After a certain age, right? We hit puberty, we peak in our early 20s. We kind of stay stable into our 30s for most people. Some people, depending on, if they had some type of illness or whatever else, for the most part, will continue to be at that peak into their 30s, and then women will start to decline, and then they will have a rapid decline during perimenopause and menopause, and men will just kind of peak at their 35ish and then just go down slowly. But 1 in 5 men in their lifetime will have a hip fracture. The mortality is higher based on different reasons because less men do have hip fractures. So it's usually the people who are sicker that end up with them. All right, Patrick, osteoporosis is a woman's problem. Men do not need bone scans.
Despite the American Medical Association and the Academy of Family Medicine not recommending bone scans routinely for men, this is not just a woman's problem. Just because we don't have a scan that's recommended for it doesn't mean it's not a problem. 1 in 5 men will have a hip fracture. We have 2 personal members from our patient panel that were in the hospital in the last month with hip fractures. There's no correct evidence on when to start scanning, but we should.
Great answer. My DEXA was normal, so my bones are fine.
Ooh, so this is a tough one because DEXA is the gold standard. This is what we use in the United States, but there's a lot of emerging evidence, especially around European unions that are testing ultrasound-based bone density. So they're using these to not only tell how hard a bone is, but the risk of fracture, the fragility. So speaking of, I had a gentleman who has a history of osteoporosis get his REM scan today with Dr. Spielberg, and it was the exact same T-score and Z-score of his DEXA scan. So there was no difference between the two, but his fragility score was very low. So he's not at risk of having a fracture despite him being on the cusp of osteoporosis.
And I guess for a little bit of clarity for people that don't understand or don't know, bone is a living tissue. It is not just a calcification. So it's not like finding a seashell, on the shore and some of them are broken, some of them are not. It is literally inside the bone where, cells are being produced, especially the osteoclasts and the osteoblasts, which build and break down bone. It's not a static process. It's dynamic and it's constantly happening no matter how old you are. As you get older, it lessens. You have more destruction than you do have building at all. But even people with osteoporosis, they still have bone being built. They just have more bone being destroyed. And so that bone quality really is a product of that. The bone density as well, but the bone quality really inside the bone and how that structure is the most important thing.
And I'll say pro and con about DEXA scans versus ultrasound-based scans like REMS. The pro of an ultrasound is it does not have any radiation. It tells us the fragility and we can do it more frequently. The cons are insurances just aren't paying for these right now and they're not very common. The pros of a DEXA scan are that it's very common, it's validated, and you can get your insurance to cover it. The cons are it has a small amount of X radiation and there can be some false positives because of calcifications as you get older. That wear and tear that happens to joints can make it artificially look stronger than it is. But like you said, it's brittle.
Yeah, not enough radiation to not do it. Definitely go do it if that's your only option. REMS, the bone density ultrasound, we can do it as many times as we want. That's the good part. There's no use in doing it more than every 6 months, though. So if somebody's telling you to get it done every month, that's snake oil. They are trying to make money off of you. So don't let anybody fool you into believing that you should be getting your bone density scanned that often. The REMS also does have the benefit of telling us the body comp, but not as good as the DEXA scan. So DEXA scan is the true gold standard for body comp, other than the water method, which you're not going to find anywhere.
All right. Next question for you is, people with osteoporosis shouldn't lift heavy. It's too risky.
False. So again, I won't call it snake oil because nobody's going to make money off of you not lifting with osteoporosis. But everybody with osteoporosis should be lifting something, right? Obviously, I'm not telling the extra frail 95-year-old grandma to go pick up, 100 pounds. It is based on the strength that you start with. And a lot of that is based on their grip strength, as we've discussed previously. Grip strength is one of the ultimate predictors of longevity, meaning the opposite of mortality. So the stronger the grip strength is. So depending on how you start, some people will literally start with 5 pounds. Their maximum they can lift is 10 pounds. So they're starting with 5 to 8 pounds, and then progressive overload, meaning that as they get stronger, they increase the amount of weight that they lift. And again, it's a dynamic process. There's no end answer in medicine other than, when you pass away. But lifting is one of those things. You use it or you lose it. People who lifted more when they were younger, like ourselves, we're lucky that we did it because we will have higher bone density and much less chance of having a fracture when we're older. I highly doubt either one of us will. Only time will tell. But that doesn't mean that we stop lifting now. That means that we continue to lift. We continue into our 60s and 70s, putting a barbell on our back. And if you can't, using things like I've literally gone to the gym with a patient and had them sit on the leg lift machine, where basically you're on your back and you push the weight. And I just had her do a static hold where she was literally just putting pressure on the legs, which is forcing compression on the bones, which is going to have a stimulus to increase bone density. People with osteoporosis shouldn't lift heavy. It's too risky.
So I hate this claim because I feel like it bubble wraps our patients. They are fear-mongered into doing less activity that they did before, and this can only accelerate bone loss. So this is a one-way street towards pharmaceutical options as your only option, rather than looking at this holistically from a nutrition, exercise, supplementation, hormone, and medication pathway as it should be. So there's great data from the Lift More trial. There's a lot of societies out there. There's the Onero method, where we can safely load somebody that has osteoporosis or osteopenia and progressively overload those bones through compression and tensile strength to make them stronger. Because bones are living tissue. They're not static things held up in your 8th grade science class.
Great answer, Dr. Mullen. Ooh, calcium pills are all I need for strong bones.
Ooh, calcium pills are certainly very dense. It doesn't necessarily mean that all of that calcium will go to your bones. So getting the correct amount of calcium is important based on first your diet and supplementing if there's any specific reasons for it. You also want to make sure you're taking vitamin K2 as well to help with that absorption and directive of calcium in your body. You don't want to take enough calcium pills until you get a kidney stone. That's when you take too much.
And I think it needs to be mentioned that the form of calcium that you're getting in the majority of supplements is not a bioavailable form. So if you want to just go grind up some seashells and eat them, you can do that because that's what most of the calcium pills are made of, calcium carbonate. And so it's the quality of the calcium you're taking, which is why getting it from food is better. However, some of the fortified foods that you're getting are just calcium carbonate again. So taking calcium with the right cofactors being vitamin D, K2, magnesium, phosphorus, which, if you're taking your calcium with food, you can do that. So that also needs to be said. Patrick, this one is for you with your board certification in obesity medicine. My GLP-1 is all upside. The weight is just melting off.
So again, when you're focusing on weight with a GLP-1, you're looking at the wrong metric. You should be focused on preserving your lean body mass and trying to isolate specifically your visceral fat and your body fat percentage during that process. These are extremely powerful medicines. They work no matter what. That's why they're really popular. It matters the composition change that you're getting through your diet, through your activity stimulus, and the dose of these. So don't be wooed by the label and the amount of weight that people are trying to lose. Set your goals based on body fat percentage or an actual internal health metric. Don't just focus on the weight.
I think people need to understand that these are a total game changer. These are life-saving drugs. I've had patients who were morbidly obese who spent 30 years doing everything they could to diet and nothing worked. Even Ozempic didn't work. And now that we have Mounjaro, tirzepatide, I'm seeing those same patients who struggled for years losing 60, 70 pounds. Of course, it's very important that they're not losing muscle mass. However, when you are morbidly obese, it is necessary to lose that amount of weight to start getting the benefit from the visceral fat and the metabolic benefits. But those people still need to eat protein. They still need to exercise. And, I have a diabetic patient who was on the highest dose of Mounjaro, 15 milligrams for the past couple of years. And I was like, hey, your blood sugar's fine. Like, we could probably taper this back. And he didn't want to. And I was like, trust me, you're going to start gaining some muscle if we do this properly. And sure enough, we've cut the dose in half. We've still taken him off of more insulin and he's gaining muscle. Just because it's solving one problem doesn't mean that we have to ignore everything else. I think that's the biggest, the nuance part with the GLP-1s that your most doctors, regular doctors, are not going to take the time to figure out, especially if you're getting them from online, because those, it's literally just a transaction. You pay them, they give it to you, you manage it yourself, which is an absolute, it should be illegal because patients do not understand the physiology and the pathways that are needed, the mechanisms that we need to control when prescribing these drugs, especially our office having the in-body scan. And some of the in-home scanners, they're okay, but they're not really going to give you what you need. You need to find a place where you can get a true impedance scan, or at least, once every 6 months, go and get a DEXA, because it is that imperative that you control your body, your muscle mass, and your visceral fat.
All right. So a good one for you, Dr. Rossi, with all these TRT clinics that are popping up on every corner, does testosterone therapy cause prostate cancer?
That is false. Testosterone therapy does not cause prostate cancer. There are certain types of prostate cancer that the testosterone can make it worse through, androgenic signaling. However, there is now evidence that the prostate cancer cells act as a threshold. It's like a certain limit of testosterone, and the men with low testosterone actually have the worst forms of prostate cancer. Part of the reason why we know this is because guys who were on finasteride and dutasteride for hair loss ended up with the worst forms of prostate cancer, the most aggressive. The trick is now, after they've had prostate cancer and they've been treated, does reintroducing the testosterone make it worse? And now we do have evidence of natural testosterone. For example, after guys go on androgen deprivation therapy, once they come off, some guys' testosterone rebounds to super physiologic levels. They go over 1,000 and then they come back down. Some of those guys, we're seeing the prostate cancer come roaring back. Some of the guys were not. So there's nuance to it, and we don't have all of the data yet. I do believe over the next 5 to 10 years, we're going to have a bunch of that data, as millions of men are now on TRT for a really long time. One of the worst things I see is the guys that have been on TRT since their 30s, because, some doctors said that was okay and they've been shut down for all of these years. God only knows what we're going to see with those people. If they were kept in physiologic range, hopefully nothing. But as this evidence comes out with millions and millions of men being on dutasteride and finasteride for their hair, for hair loss, and at the same time being on testosterone, there'll be a lot of interesting data coming out.
So anabolic steroids are a clever way to build bone density.
That's completely true. And it really, as we've mentioned several times already, the prostate cancer risk, any man who has or has had prostate cancer, you do not want to use anabolic steroids because it is the DHT molecule that is really the signaling pathway that we know about. In the future, we may have a different story. The biggest one is that older women should not ever touch these drugs. However, at low doses, there are no negative side effects, including no liver issues because the steroids are alkylated, so they do have to be processed by the liver, but at low doses, there is no negative effect, especially short term for a couple of months, which is what you want to do with these steroids. And you can see dramatic increases in muscle mass. Even if you don't see a dramatic increase in bone density, you will, for a matter of fact, have increase in bone density. Is it enough to reverse osteoporosis? You'd probably have to do it for much longer, but just the increase in muscle mass can help to prevent a fracture, not just from their increased ability and weight bearing exercise now that will increase bone density, but also the fact that you're protecting the bone.
I love it. So higher testosterone means better results.
That's snake oil. So we have way too many bad testosterone clinics online, especially when they're not monitoring men's doses. It is hard to control how much testosterone people are using. So back in the day, you had to go to the clinic once every 2 weeks and you would get injected. That's a terrible way to do it because your testosterone peaks and then it goes really low. And so you're literally doing this all the time because the esters are just not long enough for your body to metabolize it slowly enough. Once you reach steady state, maybe you can maintain 400, but at the same time, you're probably also shooting up to like 1700. So back in the day, all of these, it used to be urologists that were doing it. They were the culprit of, what I'm talking about. Now it's the fact that you get your testosterone online, and then a lot of these guys, what they do is they tell their doctor, "Oh yeah, I'm only using 0.7 ml," and what they're really doing is they're doing that twice a week, or they're shooting up twice that amount. And then when they go to get their numbers tested before their lab test the week before, they take a lower dose, so their testosterone looks lower. There's also a lot of places that just don't test. They let them tell me how you feel. And then what they do test for is they test for their red blood cells. It's laughable. I can't believe this is what doctors are telling people. Like, oh, go give blood. So you have this guy with his hematocrit, his level of red blood cells, super high, and that increases the risk of stroke and heart attack because it's literally increasing the viscosity of the blood. It's like motor oil, right? It's harder for it to go through the arteries. It puts pressure on the artery walls. It increases the water volume because the red blood cells need more water. So the blood pressure goes up. You have hypertrophy of the heart. And so this increases the risk of heart attack and stroke. That's where you get the misconception of testosterone doing that, but it's only through poor management of testosterone therapy. So realistically, anybody that's over 1,000, if you need to give blood because your testosterone is so high, that's the first sign that your doctor doesn't know what they're doing and they don't care about your health. You never want to have to give blood just because you're on testosterone. That is a really old school way of doing things, and it's been proven to be harmful.
So with testosterone therapy, I love to look at the Traverse trial, one of the major trials that opened up the doors for testosterone. It became an evidence-based way to treat folks. Again, the bounds of this study were a normal and physiologic range. As long as people stayed within 400 to 750, they remained in the study. If they went too high, they were kicked out. So we know now that normal physiologic ranges are safe for us to use. And this, again, inspired a lot of people to use testosterone, and they are now going well beyond the bounds that we know are safe. So we know the long-term effects from testosterone abuse, whether it's through professional sports or wrestling or just bodybuilding in general.
How many professional wrestlers have died in Florida from steroid abuse? Randy Savage was driving down 41, literally not too far from here, and had a heart attack in his car. Yeah. So yeah, we know very well from them.
So again, it's making sure that you're doing this within bounds and then making sure you're monitoring things. We've talked a lot about prostate cancer, and there's a lot of fear around prostate cancer, making sure you're checking and tracking PSA levels. Again, it doesn't cause cancer, but it's definitely fuel to the fire in some individuals. And this is a good excuse to bring men in to test more frequently because, again, there's that fear around prostate cancer screening, not wanting digital rectal exams, that they just don't look at these numbers.
Yeah.
And then you're looking at blood counts, you're looking at blood pressure, you're looking at heart rate. Again, when we're walking around town, we can see folks that are on testosterone therapy, the ruddiness that's around their face and upper chest, and you can just tell when somebody's levels are too high. All right. Hormone therapy is dangerous for women. The 2022 Women's Health Initiative. Hormone therapy is dangerous for women. The 2002 Women's Health Initiative told us that.
So we're living in a amazing time for female hormone therapy because just last year, I believe it was, they came out with that announcement that they're removing the black box warning, and so all of these women who had suffered from, severe symptoms of menopause, perimenopause, not all women, but a lot of women had a lot of trouble, and their doctors told them that they couldn't get hormones. You have women coming in and telling us that they were begging their doctors to get them, and they said no because it's going to increase your risk of breast cancer. When in reality, that number was so low that the data was actually inconclusive, and it was based on old school hormones. So the amount of the rate of change that we've had in the pharmaceutical industry over the past 30 years because of technology has been absolutely incredible. And so one of the things that came out were, bioidentical hormones, meaning that on a chemical test, you can't tell the difference between the hormones. They're not synthetic. So the ones that we had that were at the root cause of the issue were these old school synthetic hormones. I believe one of them was taken from horse urine. And so you have these drugs that we don't even use anymore that were the culprit for a very small increase in the risk of cancer. So we have proven evidence now that not only are hormones safe for women, for the most part, they do more good than harm. So the risk reward benefit is there. We have decreased risk of UTIs, which is a huge problem for older women, and why we see a lot of older women end up in the hospital because of the vaginal atrophy. And so we can do that two ways, whether it's systemic or whether it's vaginal. And that's actually a significant treatment for women with frequent UTIs. And it's not systemic. So even women who have had breast cancer can take vaginal estrogen. And on top of that, you have what we're now seeing: cardiovascular benefit, the benefit in bone density, decreased risk of dementia. So as the evidence is coming out, we're finding more and more that not only is it not harmful, it's actually better for women to be on hormone therapy as they age. Obviously, there are some women with hormone receptor positive breast cancer that should not be on it, but otherwise, it's generally safe and effective.
So I feel like the Women's Health Initiative is a great example of how sometimes the media can react to things in a lot of different ways and how reactionary the practice of medicine is. So the big headlines after the Women's Health Initiative are that it's a 50% increased risk of breast cancer in the treatment group. And again, that sells a lot of headlines, that provides a lot of fear mongering. The absolute data that there was one extra person with a diagnosis of breast cancer out of 10,000 folks. And again, this was not in the estrogen group. This was in the synthetic progestin group. The estrogen group didn't have that risk. So again, taking out of proportions, not followed up with the nuance, not following up with the actual data was the tough part. And again, just like most things in medicine, when we see a study or something, we react to it and we move in mass. There is no nuance with something. There is no personalization. There is very much a, this is all good or this is all bad.
And I've had this discussion with some women who tell me, I've had a history of breast cancer in my family. I don't care. I still want the hormones. And at that point, you have to have that discussion like, hey, if you're telling me that there is a massive chance that I'm going to kill you with this drug, there's no way I'm giving it to you. But if you're telling me, oh, hey, there's a remote possibility of a small increase and you understand that risk, well, it's up to you. And if it's beneficial for your symptoms and everything else, and that's what you want, then okay, we can think about it.
Yeah. And I really love our practice and the style of how we do this. It's never that, if we treat somebody with hormones or not, we make any difference in terms of the bottom line. Our members pay us for our time and expertise, and it's very much personalized towards their goal. This isn't a hormone clinic where we want to sell everyone on hormone therapy. If we explain the risks and benefits to our member, we act as their guide and their fiduciary, we can decide whether or not that's a great treatment and they're willing to accept that risk. I have quite a few members that recognize the benefits that hormone therapy could have. They still have fear or questions around it, and we decide not to do it.
That's perfectly fine.
Yeah. Again, doesn't affect us. We are your guide. And that's where sometimes hormone therapy can be taken out of context when you are going somewhere and paying them as a transaction to get this done. If you pay somebody, their incentives are always going to be all the positives, none of the negatives. And then they're going to incentivize you with more and more and treat the symptoms, not treat the underlying disease, not get the levels to where we want them and safely do so.
I think it's really mind-boggling how many bad actors we do have in Sarasota that they're really pushing hormone therapy as a cure-all, and it's total crap. It's not true whatsoever. Are there a ton of benefits? Absolutely. Is there a safety profile? Absolutely. Is it, should it be individualized? Absolutely, which is what we do, and a lot of places don't. They literally have, the pellets already ready to go. And they're like, oh, come in, get your pellets out. And they don't do any testing. There's no discussions. There's none of that. And so a lot of the times what they'll do is they'll give enough to have symptoms of overdose, and then they'll back off. When in reality, you should be doing the exact opposite. You should be starting at the low end of the spectrum and slowly increase to where you hit a sweet spot and never, ever reach that upper limit.
Yeah. I find it interesting. We work with a lot of different doctors around the community, and some of them are surprised when they hear that we do pellet hormone therapy. Once again, not as the only option, but one of the options that members can choose from. And they're surprised to see that their testosterone and estrogen levels are not through the roof, that they're in a normal range of testosterone of 36 on someone that I saw yesterday with testosterone pellets. It's not something where we send a woman's level to that of a teenage boy and we're getting side effects. We're doing the lowest possible doses to make sure that we're resolving symptoms without causing any harm to our members. Because in the end, if we cause harm to our members, we have to go to the hospital, and that's not their favorite day or our favorite day.
Yeah, I think the level of knowledge of hormones, good or bad, in the medical industry right now is absolutely mind blowing. It's like, you and I know how to use a circular saw, and when you're cutting a 2x4 versus when you're cutting a piece of finished wood, you're going to use a different saw blade, and it's like you wouldn't use a hammer to put a screw in. You'd use a drill, and you drill a pilot hole and you make it look nice and neat. Or you could just go in and you could do a hack job on everything. I think that's the way like I see hormone therapy in the industry right now. It's absolutely wild.
Yeah, I think the Dunning-Kruger effect, right? You can go to the same place that does your Botox and filler, and now they're starting to sell you peptides and hormones and call themselves wellness or longevity without having the actual nuance and training behind it, right? Some of those people are the most confident because they only see the positive cases. Only the patients that love them go back to see them. They never see, the product of some of these harm patients that will go somewhere, have a terrible result, and never go back to see them.
I was going to say it's their own patients that get the terrible result and never go back, which is actually kind of incredible that there's that low level of accountability, as well as the fact that, the Dunning-Kruger effect, just enough to be dangerous. It's pretty wild.
Yeah, I feel like in this day and age of social media, and one of the reasons we want to speak more to our members and other folks is that it's education. It takes a long conversation. This can't be done in a 7-minute visit. We spend hours with our patients throughout the year to get to know them, to ask the right questions, to do the follow up, and make sure that we're doing a great job. And again, it's just not common in this area, and we want to explain that a little bit more. It's tough to get across that you're an expert in something because the fast claims on Instagram and the do this now and the confidence that you get from a lot of these influencers looks like expertise, when in reality, expertise is a lot more nuanced, and there's a lot of it depends.
Yeah. That that kind of leads to something that I don't know if I should say it or needs to be said, but we don't actually like doing this. We don't actually like being on camera. We're doing this to get the information out and help people to understand. I think that's the benefit of what we're doing, to kind of to our own detriment. But we're here and we're doing it, and I'm glad that people are going to learn from it.
Yeah. Once again, I am a total nerd. Sheen and I can discuss these things for hours, and I hope that people can understand that we truly know what we know, and we want to bring that to patients. But I would much rather do this one-on-one with a patient, because it's very difficult to make claims and substantiate things when there's a lot of gradation, and it depends on their individual goals, and that's something we do with our members and we care deeply about.
It's amazing to think about, but there shouldn't be in medicine. One of the things that I talk to other doctors about is like, no one day is the same for any of us. When I was in the hospital, no one day was the same. The crazy thing is I would go in there and I would see 15 patients that I've never seen before. I would save some of their lives. I'd had conversations with their families and I never see them again. That was the crazy thing about being in the hospital. And now at least that I have a panel, I see some of the same patients over and over. We know each other very well, but still the conversation changes every single time. Different symptom, different problem, same thing presenting differently. How are we going to do X, Y, and Z, adjusting this, adjusting that? And so, and as they age, right? So all of this stuff that we're doing, there's so much nuance to it that we can't just come on and do a podcast and give everybody all this information. It literally has to be done one to one. This will be good because this will open up people's eyes. We may save a couple of people who are like, oh crap, I'm going to that testosterone clinic. I need to stop going there because they just literally named 7 of my symptoms. It's you. So like literally we may be doing some good with this as well as just providing general education.
Yeah. And again, the medical community in general is, filled with wonderful doctors, wonderful people. Nobody
Absolutely.
means to do harm.
100%.
It's just the systems that they exist in. Again, one that's driven by insurance, it's limited by time, it's capitated by the number of members a doctor has to see.
Yeah.
And then another one that's driven by, again, profit or pay per service, where again, their intentionality is great, but their incentives are a little bit towards, more is better. Being on our side of things, trying to be patients' guides, working with them for the long term.
And see as few as possible form those relationships.
Yeah, because again, those relationships last for a long time. I would much rather keep all of our members for a very long time than have to advertise and look for new members. So our goals are aligned. We want our members to be healthy, happy, alive as long as they would like to be so and achieve all of their goals. And we give them the plan to do that. It's very individualized. And like we've talked about a lot, it changes over time and we are ready to react to that. We know them by name. We can answer the phone when they call and we can make sure that they get what they need.
Yeah.
I think that's a wonderful way to wrap things up philosophically. Let's go save some lives.
Let's do it.